Hello everyone, I'm Taha. I'm a fourth year medical student, and in this video we're going to go over the pathophysiology of asthma. Alright, so let's jump straight into it. Just to understand asthma a little better, we're going to introduce a patient. Alright, so let's imagine we have a patient and his name is Mr. Whitecoat. Alright, so Mr. Whitecoat comes to you and he has asthma. So let's understand the pathophysiology of asthma so we can treat Mr. Whitecoat accordingly, okay? So the pathophysiology of asthma is a little difficult to understand, but if you break it down into three main headings, we can categorize it quite well, okay? So let's have a look at what the first heading would be. So asthma can be characterized by airway, or I should say chronic airway inflammation, right? And this really is the backbone of what asthma actually is. So asthma is a chronic condition of the airways within patients' lungs, alright? And it can cause episodic periods of bronchoconstriction. This is when you've seen patients who may have had an acute asthma attack and they're, wheezing and they're out of breath, and that can be reversed through things such as inhalers. Alright, so we'll have a look at that further in this video. So the first heading would be chronic airway inflammation. The second one would be, like we mentioned, reversible bronchoconstriction. Okay. So reversible bronchoconstriction, like we mentioned, you have probably seen patients who are able to take inhalers, and that can alleviate the symptoms of asthma. And the final thing that we can break down is something called hypersecretion, right? And hypersecretion of what exactly? So hypersecretion of mucus within the airways of the lungs, right? All three of these contribute essentially to airway constriction, okay? And when the airways of the patients are constricted, as you can imagine, right? Let's imagine these are the airways within Mr. Whitecoat's lungs. In under normal conditions, the air will be able to pass through the lungs without any problems, right? Although in asthma, like we mentioned, there's chronic inflammation, and let's understand why the chronic inflammation exists in the first place. So, the reason why there is chronic inflammation in patients with asthma is because their lungs are hypersensitive to certain stimuli, right? Stimuli that may otherwise not cause, an acute exacerbation of symptoms in other people, but will cause symptoms of asthma within patients who have this condition. So those sort of common triggers may include things such as pollen. It may be things such as cold weather. It can be exercise. It could even be cigarette smoking. So any sort of thing that irritates the lungs, these then triggers go within the patient's lung and cause an overactivity within the body that leads to the chronic inflammation. As we know, with any sort of inflammatory process, the tissues that are inflamed become swollen, and as these airways become swollen, they constrict, right? And this constriction leads to the narrowing of the actual bronchi and the bronchioles within the lungs. So when the airways constrict, it means less air can actually pass through. Now, when less air is able to pass through the lungs and the airways, we get the characteristic sort of wheezing, right, sound that you might have heard with patients who have asthma. It can also lead to the shortness of breath that patients experience. You can also experience tightness, right, within the chest area, because it quite literally is constricting of the airways within the lungs. And sometimes there can even be pain involved during this process, right? As well as coughing. So that process is what we call the chronic airway inflammation. Now, reversible bronchoconstriction, this is when the smooth muscles within the airways. So let's have a look at Mr. Whitecoat's airways, right? So here we have the lungs, right? We have the left lung and the right lung, and then we have the trachea that comes down and then splits, okay, into the left and the right bronchi, then further splits into the secondary and the tertiary bronchi, into the bronchioles, and then into the alveoli, right? Now, the actual airways are also covered with smooth muscles, okay? Now, these smooth muscles can constrict, right? And it is known as bronchospasm. Now, when these airways constrict, they again narrow, okay? Which means that less air is able to pass through, and again leads to the symptoms that we've mentioned here, right? The final thing that we can look at is airway hypersecretion. And what does that mean? Airway hypersecretion is, we need to first understand that these airways are also lined with certain types of cells, right? These cells are known as goblet cells, right? Goblet cells secrete something called mucus, okay? Now, in otherwise healthier patients, this mucus is also very important in the normal functioning of the lungs, as it traps certain pathogens and allows us to then swallow the mucus and kill off the bacteria that may cause us infections. But with patients who have asthma, this mucus production is increased highly, okay? Now, when this mucus production is increased, it means that it further contributes to the narrowing of the airways. Okay? So, in the end, you get an effect of all three processes. So, chronic airway inflammation, reversible bronchoconstriction, and also hypersecretion that leads to the characteristic features of asthma. Now, one other important thing to mention here is that asthma is also known as an atopic condition. Okay, so let's understand what this means. Atopic conditions are, it's an umbrella term that means that there is a group of conditions that may coincide within patients and oftentimes run in families. So asthma would be one of the atopic conditions. You may have also seen patients who have asthma may also have eczema and also hay fever, right? So these can often run within siblings, families, and patients may oftentimes have multiple conditions at the same time.
So we'll have a look at the different clinical signs and the typical presentation of what asthma actually looks like within patients. And we'll also jump into a little bit of why those symptoms are actually occurring. So let's jump straight in. So we'll welcome our patient back, Mr. Whitecoat, right? And we'll go through just some of the classic presentations of what asthma and how it presents. So we understand the physiology of asthma is that it is a chronic condition, right? Now, even though it is a chronic condition, this doesn't mean that the patient will always experience the symptoms that we're going to talk about. So it's not a perpetual thing. It's defined as a chronic condition that's exacerbated acutely, and we'll have a look at what causes those sort of exacerbations. So we will look at the first symptom is the classical wheezing, right? The second one we'll look at is cough, and the very last symptom we'll look at is dyspnea, right? So let's have a look at the wheezing aspect, okay? So the wheeze in asthma is actually what we call a polyphonic wheeze, right? I'll explain what this actually means. To understand what polyphonic and monophonic wheeze actually is, we'll look at the pathophysiology of why the wheezing actually occurs, right? So within Mr. Whitecoat's lungs, the wheeze occurs by a constriction of the airways, right? So if you imagine within a normal patent airway, right? So this is a normal airway. Air will pass through this airway, right? And it'll go out without making any sort of, turbulent sounds or high pitched whining or any sort of pitch, really. Now, in asthma, as we know, there is inflammation. And as we know in inflammation, when inflammation actually occurs, we also get smooth muscle constriction. Now, when the smooth muscles actually constrict in asthma, it means that there is a more narrow passage for the air to actually travel through, right? And when this passage in the airways is actually narrowed, it means that the pitch will increase, right? So the wheeze that we hear in asthma is actually just wind or air, breath, breathing, passing through the constricted airways. You can try this at home actually. If you take your mouth and blow air out through a normal patent airway, so just blow air out. Now, if you purse your lips together and blow the same amount of air out, there'll be a whistling sound, and that's obviously caused by the decrease in the area. So so that is what the wheezing is actually caused by. Now, if we go back to what the polyphonic and the monophonic means, it's polyphonic just means that the airways within the lungs, right? So all of the airways within the lower respiratory tract, so the bronchi, they all constrict to varying degrees, okay? So some airways may constrict this much, some may constrict this much, some may constrict just a little. And now the variation between how much they're actually constricting will contribute to different level of the pitches, right? So the more narrow it is, means that the higher the pitch. Now, when you have all these different types of pitches, if you take a stethoscope and put it onto the patient's lungs, you'll hear a mixed picture. So there will be different tones, and the pitch will be different in the actual airway. Now, compare that to a monophonic wheeze, right? A monophonic wheeze is not characteristic of asthma. So if we have a look at the airway again, this monophonic wheeze usually it means either there's a foreign body within the airway, so it could be a child who may have swallowed a bit of Lego. It's a terrible representation of a Lego, but you get the point. So again, same sort of idea. So when there is that sort of narrowing of the airway, it means that the air pushing past will make a pitch, right, a higher pitch sound. Now, important point to mention here is that the monophonic wheeze will only be specific to one area, right, not widespread like it is in asthma. Another thing it may be caused by is something a little more sinister, such as a tumor, right? So a lung cancer that might be growing, and that can also cause a monophonic wheezing. Okay. Now, now let's have a look at the coughing. Okay. So what is the coughing actually caused by? So we understand that it is usually chemical irritants or certain particles that go into the patient's lung, and because their lungs are hypersensitive, they have an overreaction to these irritants. Now, when the lungs are irritated by these particles, like we mentioned, they constrict, right? And this constriction can activate the cough receptors, right? It can be the constriction or the actual physical, chemical irritants themselves that can activate these cough receptors, which will trigger the cough reflex, right? And the reflex is realistically is there to help us, prevent inhaling particles that shouldn't be there in the first place. So it's trying to expel the particles and the irritants that are within the lungs. So that is one reason why cough actually occurs with patients in asthma. Another reason is because of the mechanoreceptors, right? So within the airways, there are also mechanoreceptors that respond to the constriction, right? When the smooth muscles actually constrict, mechanoreceptor responds to that and can also trigger coughing within the patient, right? Now the final thing that we'll look at is dyspnea, okay? Now dyspnea just means, it's a fancy way of saying shortness of breath or just simply SOB, okay? Now, why is dyspnea actually occurring within patients with asthma? The main reason why is because there is a decrease, right, in the patency of the airways, like we've mentioned. Now, if you imagine taking a straw, right, and putting it in your mouth and trying to breathe through that straw. Now, if you're at rest, this might be fairly straightforward and it may be simple. But if you imagine patients who have had increased workload, right, of the lungs, so maybe they're exercising or maybe they need, more oxygen delivery to the body, then when the respiratory rate increases, it means that there is a severe, lack of air actually entering the lungs. So if you can try this at home again, if you take a straw and do 20 jumping jacks, you can start to see how difficult it is for patients to breathe through these narrow airways, right? Um, so that's one way that the dyspnea actually occurs. So the second thing we can actually look at is something called dynamic hyperinflation, right? Now, what does that actually mean? So, dynamic hyperinflation means that, so we understand that the pathophysiology of asthma is that is an obstructive condition, right? Is an obstructive pathology. So it means that air cannot exit the lungs, right, as it should. So what this means is that when a patient exhales, right, there is going to be residual air, so residual volume of air left within the lungs. So it's going to be trapped within the alveoli of the patient. Now, when that happens, the patient is going to inhale again, right? And that cycle, it repeats. So if you inhale, but you haven't expelled all the air, it means that over time, that there is going to be an increase in the residual volume of air that's actually trapped within the lungs. Now, when this happens, it means that it increases the pressure, right, within the lungs, right, because there's an increase in the residual air volume. Now, when there's an increase in pressure, it also means that it's even more difficult to get air, into the lungs, and that also contributes to the SOB that we see in patients with asthma. So, so now we've had a look at the big, the three main sort of symptoms, so the wheeze, cough, and then the SOB, right? And we've also mentioned that patients with asthma don't, chronically have these conditions or these symptoms. They only come on when there is an acute exacerbation. So when during those times, when would they actually occur? So the times where patients may experience those symptoms is when there is a stimuli or irritant. So this could be things such as, dust particles. It could be smoking, could be damp, like dirty air, so sort of dirt. Some people are quite allergic to animals as well. It could be things such as exercise, because there's increased demand for oxygen during this time as well, and also things such as, cold weather. And one other important point to mention here actually is that asthma is typically worse at night. Okay, so let's understand why asthma is actually worse during the night for some patients. So we understand that cortisol, right, which is our body's natural sort of steroid hormone, it keeps inflammation down within our body. It actually is the lowest, it drops as we go to sleep and spikes in the morning, right? So as cortisol drops within throughout the night, it means that inflammation has more of a chance to cause symptoms within patients, right? Another reason is because the airways are naturally more narrow during the night. Okay. Now, this is completely normal and it happens to everyone, but obviously, because patients with asthma are more susceptible, so it typically presents worse with patients who have asthma. Another reason is because obviously you're lying flat, right, within the body, so during the night, sorry, and this means that more blood can actually perfuse the lungs, right? And this means that it can cause it to be a little bit more congested, which can also lead to some of the symptoms that we see, especially the dyspnea and the shortness of breath, typically worse throughout the night. So we'll bring our beloved patient back, Mr. Whitecoat. All right. And now Mr. Whitecoat is wondering what are the different investigation procedures that are actually available to him that we can look towards doing that may confirm asthma as a diagnosis or may point towards a different diagnosis. So, the very first thing that we need to consider is that asthma is oftentimes a clinical diagnosis, right? Now, what actually is a clinical diagnosis? A clinical diagnosis is where the doctor or the clinician will make a diagnosis based on the patient's clinical symptoms, right? So this means that the doctor will look at the patients within the symptoms, with the patient's symptoms, and will make a diagnosis based off just that without doing any further investigations. And obviously, as we can imagine, the symptoms may be very typical of the actual pathology itself. So that may mean that the doctor doesn't need to confirm or look towards alternative diagnoses. And asthma is oftentimes one of those conditions. Now, if a doctor does want to confirm the diagnosis of asthma, then there are a few investigation procedures that are available. So we'll jump into those right now. So the very first thing that we can look at is something called eosinophil count. Eosinophil count, and FeNO. Okay, so eosinophil count and FeNO. That's the very first thing. There are four main types of clinical investigation procedures that we can do. So I'll list them out here and then we'll jump into each of them. So eosinophil count and FeNO. The second one was bronchodilator reversibility plus spirometry, right? The second one is peak expiratory flow. And the very last one is bronchial challenge testing. Okay. So let's have a look at eosinophil count and FeNO. All right. So we've understood by now that asthma is a chronic inflammatory condition of the airways. Okay. Now, eosinophils is very important player in asthma because eosinophils usually increase when in response to certain allergens, in response to certain parasites, and also some types of infections. Okay. Now, the allergens is the main player, within asthma because those are typically, the triggers of the asthma itself. So, as a result, what we can do is we can measure the level of eosinophils within the bloods, right, within the patient's blood. And what this means is that if there is an increase in the eosinophils within the patient's blood, that can point towards the diagnosis of asthma. Now, what is FeNO? So, FeNO stands for fractional nitric oxide. Okay. Now, both eosinophil and the fractional nitric oxide, they play a role with each other. So what happens is within the airways, naturally the airways produce nitric oxide, right? So the smooth muscles within the airway produce nitric oxide. Okay. Now, when there is an increase in the eosinophils within the smooth muscles of the patient, the eosinophils will increase certain enzymes, okay, that will then increase the level of the nitric oxide within the patients, right? Now, how do we actually measure this? So the patient will be given a certain device, almost like a breathalyzer, but the patient will exhale into the device, and that will pick up on the level of nitric oxide that is being exhaled. Now, because we mentioned that the eosinophils will increase the level of nitric oxide to confirm the diagnosis of asthma, the FeNO is usually higher within patients who have asthma. Okay, so that's the very first one. Now let's look at the second one, which is bronchodilator reversibility with spirometry. Okay, so let's have a look at what this is. So we've also mentioned, with asthma itself, that it is it's a condition in which there is hyper responsiveness and reversible bronchoconstriction, right? That is the main, the main hallmark of what asthma actually is. It is reversible bronchoconstriction. Okay, so what we're essentially doing with these testing is trying to elicit the reversibility aspect, right? So we're trying to check if there actually is, the airways are able to expand and constrict. And if they do, then we can, confirm that asthma is the diagnosis. So what happens with spirometry, right? That's this is an important point to mention. Is spirometry will measure the patient's FeV1 and the FVC. Okay. Now, what is the FeV1? Okay. So the forced expiratory volume. Okay, within 1 second. Okay, so this is the level of volume or the volume of air that a patient expels, right, within 1 second. Okay, so this checks for the level of obstruction within the patient's airways, right? And as we've mentioned previously, asthma is an obstructive condition. So this will check the level of obstruction within the patient's airways. FVC is forced vital capacity, okay? So this is when the patients will take a deep breath in and expel all the air out. So it's not within just 1 second, it's all the air they can expel, and that checks the vital capacity. Okay, so both of these are what we measure within spirometry, and what happens is we take these two as a baseline test, okay? And what we then do is give the patient a bronchodilator, right? And when we give the patient a bronchodilator, we typically wait, 10 to 15 minutes, right? And then what we do is we repeat the tests again of spirometry, right? And we get both of these measurements again, the FEV1 and the FEC. And if it shows that there is an increased and an improvement within the FEV1 and the FEC, then we know that the bronchodilator has actually worked and it's expanded the airways within the patients. And like we've mentioned, it's reversible bronchoconstriction, so that would also point towards a confirmation and a diagnosis of asthma. So let's just go back quickly. Peak expiratory flow, that is the next one. Peak expiratory flow. So what is PEF? So peak expiratory flow is interesting because this investigation is typically reserved for patients who have already had a diagnosis of asthma. So this isn't typically, used for the diagnosis of asthma itself. We use this to, measure how the disease is actually progressing for patients, and depending on the measurements of the peak respiratory flow, we can then tailor medication and adjust dosing based on how the condition is progressing. So what actually happens with peak respiratory flow is that a patient will be given a device, right, with a cardboard tubing at the end, so right here, and the patient will then blow, so exhale in air into the device as hard as they can after a deep breath in and one big exhale, right? And the air that they've expelled will push this little slider across the device, right? And the device will be measured, it will have metrics along it, which we can then write down, okay? And using those metrics, we can then tailor, medication and dosing for the patient. And the very last thing was bronchial challenge testing, okay? So bronchial challenge testing. So what is this? So very much like the bronchodilator reversibility, this is essentially the inverse of that. So we're trying to test the level of constriction and the hyper responsiveness of the airways itself, right? So rather than trying to test the patency and if it irreversibly constricts, we're trying to see if the patient's airways actually are hyper responsive to certain inhaled substances, right? So what happens is the patient will inhale substances such as mannitol, right? And when the patient inhales these substances, we will give them at different doses, right? So we'll give them at this dose, at this dose, and at this dose, right? And and at each step of the dosing, we will measure with spirometry, okay, to check for the patient's lung function. And when this actually happens is we can see that at lower doses of the inhaled substance, that the patient will have a decrease in the lung function itself, measured by the spirometry. And if that happens, then that confirms that there is hypersensitivity for the airways, which will then confirm the diagnosis of asthma. The thing with bronchial challenge testing is that this is typically reserved for last line. So this is for patients who have persistent symptoms of asthma, but yet they haven't been able to confirm diagnosis using the other three investigation procedures. So this is typically reserved for patients who have persistent symptoms but have not had a definitive diagnosis. So we'll bring our patient back again, Mr. Whitecoat. Okay, now Mr. Whitecoat is finally wondering what are the different in management options and the different medication that are actually available to control his symptoms. All right, so let's have a look at the long-term management options. Okay, so the very first thing that we can look at when managing asthma, bear in mind all these different management options are for patients who are over the age of 12 with a new diagnosis of asthma. So the very first thing that we can look at is something known as air therapy. Okay, so let's have a look at what air therapy actually is. Now, air therapy is essentially a combined inhaler. That's essentially what it means. It's a combined inhaler of formoterol and ICS. Okay, inhaled corticosteroids. So we'll go through the brief explanation of what both of these medications actually are, but we'll go into depth of the pharmacology of the different medication in asthma in the final video in the series. Okay, so what is formoterol? Formoterol is something known as a long-acting beta agonist. Okay, so what actually is a long-acting beta agonist? A long-acting beta agonist is essentially, so beta agonists are scattered around the airways within our lungs, so specifically beta 2 agonists, right? Now, when these receptors are actually activated, they cause bronchodilation, right, of the airways. So if we go back to what the pathophysiology of asthma actually was, it was the constriction of those airways that caused the obstructive nature of the airflow. So if we open up the airways, we dilate them, then it will hopefully reduce the symptoms that the patient actually experiences, right? So that's a reduction in the constriction of the airways itself, right? Now, what is ICS? ICS is an inhaled corticosteroid, right? Now, ICS, they come in little powders, right, in ICS inhalers, and this powder will then also line the airways, and it contains corticosteroids. So corticosteroids reduce the inflammatory response that actually goes on within the patient's lungs. So this also attacks one of the key principles of the underlying pathophysiology of asthma, right? So this reduces the actual inflammation of the airways, and the beta agonist opens up the airways, right? So in combination, then we can use those to then hopefully control the symptoms that the patient experiences. One thing to note about air therapy is that it is essentially a reliever therapy, right? So what does that mean? So air therapy is a regimen that's given to patients who have somewhat, moderate and mild symptoms of asthma itself. So that means that they only use the inhaler when it's actually required. So say they have an exposure to a common trigger, such as exercise is a very common one, maybe dust, pollen, those sort of things, and then if a patient experiences the symptoms of the wheezing, the chest tightness and the pain, the shortness of breath, then they can use the air therapy, which is the combined inhaler of formoterol and ICS, and then that will reduce the patient's symptoms. One other thing to mention with the LABA is that it's actually a long-acting beta agonist, right? So in contrast to short-acting beta agonists, this lasts way longer, typically around 10 to 12 hours. So the airways will remain open and patent when you use long-acting beta agonists as opposed to short-acting ones such as salbutamol that we've commonly seen, which is the blue inhaler, right? Now, the second thing in the pathway is something called low dose MART therapy. So when do we actually go? So we go from air therapy to MART therapy essentially when patients, symptoms are still uncontrolled. So if a patient's tried the air therapy of the using it as symptomatic relief, and if the patient continues to get ongoing symptoms, then we can go to low dose MART therapy. Now, what is MART therapy? MART therapy, essentially, it just means that it's a maintenance therapy. So as opposed to the quick symptomatic, use of the air therapy, MART therapy is a maintenance therapy. So this means that it's essentially in terms of its pharmacology, it's essentially the exact same drugs. So you still have the combined formoterol inhaler, which has both the ICS and the LABA inside, but the only differentiation is that it's the timing of the use, right? So this is used as a symptomatic control. This is used as a maintenance therapy. So patients will use this typically 1 to 2 times a day, and this means that there's ongoing bronchodilation and the reduction in the inflammation that the patient experiences. So a reduction in those for a longer period of time should hopefully control the patient's symptoms. Again, though, if the patient's symptoms are still uncontrolled on low dose MART therapy, then you can probably guess what's coming up. It's going to be high dose MART therapy, right? So, to no one's surprise, this is exactly what it sounds like. Exact same, medication, just at higher doses. So again, with the combined inhaler, you just have a higher dose of the LABA and the ICS. Okay. Now, the fourth thing is interesting because at this stage, what we're going to do is we're going to check the FeNO and the eosinophil count of the patient, right? Now, what is the importance of those? So FeNO, like we've mentioned in the investigations video, FeNO and eosinophils are typically raised with the patients who have asthma, right? This is a very typical biomarker. Now, if we measure these with patients, even after they've gotten the previous three, management options within the pathway, then what happens is if these are increased, right, it means that the underlying inflammation in the inflammatory process is still going uncontrolled, right? It means that the eosinophils and the FeNO are still raised, and that means that the inflammation is still having been controlled by the drugs that we've given, and that means that we then need to either increase the doses or we need to add in more drugs. So what drugs can we add in after that? We can look towards LTRAs, okay, and long-acting muscarinic antagonists. So we can add these medication on top of the low-dose MART therapies for typically 8 to 12 weeks, and then reassess continually. But let's explain what LTRAs are. So LTRA stands for leukotriene receptor antagonist. What are leukotrienes? Leukotrienes are essentially mediators within the body, right? And when their receptors are activated, they increase the mucus production in the airways, the constriction, so they increase the mucus production, they increase the constriction of the airways, and this means that there is, it increases the amount of the underlying pathophysiology that's actually going on in asthma. So if we can block this receptor, right, that means that the leukotrienes can't have this effect, and hopefully that will help alleviate some of the symptoms. Now, long-acting muscarinic antagonists, what are those? So muscarinic antagonists, right? They obviously, as inferred by the name, they block the effect of muscarinic receptors. Now, when muscarinic receptors, when they are bound, so when acetylcholine binds to those receptors, it causes bronchoconstriction, right? That's their action. So if we can block those receptors, we're essentially blocking the constriction, which then means that there is a long-lasting effect of bronchodilation within the airways. Okay, so that's if the FeNO and the eosinophil counts are raised. Now, let's assume that the eosinophil count and the FeNO are not raised, right? What does that mean? So that means that if after all this medication that the eosinophils and the FeNO are not raised, it means that it's an atypical presentation of the asthma, right? And that means that it's not going to be well controlled by the drugs because they target, the typical presentation. So then that means in that scenario, we would look towards specialist referral, okay? We will then refer them towards specialists who specialize within asthma management, and then they can look towards, allowing for better treatment and management of the condition.